All right, Protocol 10 is our spinal immobilization clearance protocol. And just a note on this protocol, your default is to always immobilize your patient. If there is any doubt, we immobilize. This protocol is based upon 7 assessment findings or questions. If the answer to any of those 7 questions is yes, then we will immobilize the patient with long board, cervical spine immobilization collar, and cervical immobilization devices or head blocks in place. All right, again, default is always to immobilize. And just a note, in the very young or the very old, a normal exam may not be sufficient to rule out a spinal injury. So there is an acronym that's going to help us remember this assessment, and that is NSAID, usually stands for nonsteroidal anti-inflammatory drugs. However, in this case, the N will be the neurological exam. We're going to look for focal deficits such as tingling, reduced strength, or numbness in the extremity. The S stands for significant mechanism or extreme age, so the very young, the very old, or there's a significant mechanism of injury. The A is alertness. Is the patient oriented to person, place, time, and event? Any changes in alertness with the incident? I is for intoxication. Is there any indication that the person is intoxicated, impaired decision-making ability? Distracting injuries for the D. Is there any other injury producing pain in the patient? Any injury which the patient seems to focus on, and we determine this by them rating that pain at a 6 or greater on a scale of 0 to 10. And the S is for the spinal exam. We're looking for point tenderness in the spinal process, or spinal process tenderness with range of motion. Each of the 7 cervical spinal processes must be palpated during the exam. If the answer to any of these is yes, we will immobilize the patient. Okay, so Protocol 11 is our airway protocol and is a general protocol in dealing with an airway. It gives us kind of the tools that we have at our disposal. The first of which is the King Airway, or the blind insertion airway device, which is for all provider levels. And next is the intubation procedures for the I provider. It's oral tracheal intubation over the age of 12 years old. And for the P provider, it is any age, oral tracheal intubation. For the P provider, you also have adult nasotracheal intubation. Patient must be over 12 years of age. And you have airway cricothyrotomy procedures. We're also going to talk about post-intubation sedation if needed. So just to review, our EMT through paramedic level, basic airway maneuvers, spinal immobilization procedures if indicated, and the blind insertion airway device, or the King Airway. For our IMP level providers, direct laryngoscopy for our foreign bodies, and needle decompression for our tension pneumothoraxes. And for our P providers, airway cricothyrotomy procedures and post-intubation sedation. Okay, paramedic level providers. Let's take a look at this post-intubation sedation. How we do this is we administer fentanyl at 100 to 150 micrograms, and this is not weight-based, IV or IO, and or administer ketamine, 2 milligrams per kilogram, IV or IO. Now that ketamine dose is the dissociative anesthetic dose. Your patient is already intubated. The post-intubation sedation for pediatric patients, we're going to administer ketamine at 0.1 to 1.5 milligrams per kilogram IV or IO. Just be aware that when we administer fentanyl and ketamine together, we need to be on the lookout for a synergistic effect. Protocol 12 is an airway failed protocol. It basically gives us guidance on when to for our paramedic providers, head to the airway cricothyrotomy procedure. But also don't forget, for our I and P level providers, we do have the option of the blind insertion airway device if intubation is unsuccessful. Now there's a note on this protocol: 2 failed intubation attempts by the most proficient technician on scene, or the patient has anatomy that's inconsistent with intubation attempts. That's when we use the airway failed protocol. Each attempt should include a change in approach or equipment, and for intubation, no more than 3 attempts total. Okay, for all provider levels, don't forget, if indicated, insert the blind insertion airway device. If unsuccessful, call for ALS, and of course we are using the King Airway for our BIAD. Okay, so for our paramedic providers in the airway failed protocol, Protocol 12, airway cricothyrotomy procedures. When is this indicated? This is indicated when you are unable to bag your patient and maintain an SpO2 of 94% and a normal end tidal of 35 to 45. It's when you have failed in 3 intubation attempts and you have failed to insert the blind insertion airway device or the King airway. Also, if your patient has significant facial trauma, swelling, distortion of the airway, and time does not allow for other airway procedures, you are indicated to perform an airway cricothyrotomy, whether that be surgical or a needle cric. And again, we're going to cover both of these extensively in the skills training. All right, protocol 13 is our cardiac arrest asystole PEA protocol for adult patients. All of our cardiac arrest protocols follow the ACLS guidelines, so no real change here in your treatment from your current protocols. Just a reminder, we need to consider the causes of our cardiac arrest, so our H's and T's, considering all possible causes listed in the differential, and survival is based on identifying and correcting that cause of cardiac arrest. Consider a discussion with medical control. Protocol 14 is our cardiac arrest asystole PEA pediatric, and again, covering all PALS and ACLS guidelines. No real change from your current protocols you're working under now. At any time, if you do have a return of spontaneous circulation in either of these protocols, you need to go to the post-resuscitation care protocol. And for pediatric, it's protocol 16. For adult, it's protocol 15. All right, also consider bilateral chest decompression in traumatic arrest for both adult and pediatric patients, and once again, refer to the appropriate protocol for return of spontaneous circulation. Okay, so here's the post-resuscitation care protocol for adults, and we're going to cover this extensively in the next slides. For our advanced providers, if we do regain a pulse or have return of spontaneous circulation in our cardiac arrest patients, our advanced through paramedic providers, we need to focus on maintaining that blood pressure greater than 90 millimeters of mercury systolic, and we do this by IV normal saline boluses of 30 milliliters per kilogram to a max of 2 liters. Our I&P level providers also have the option of administering dopamine at 5 to 20 micrograms per kilogram a minute to maintain that blood pressure again at 90 millimeters of mercury systolic. And our paramedic level providers have the option of post-intubation sedation. If your patient starts to come around, starts to chew on the tube, paramedics have the ability to give fentanyl 100 to 150 micrograms IV-IO and or ketamine 2 milligrams per kilogram IV-IO. And remember, the pediatric dose for post-intubation sedation is ketamine 0.1 to 1.5 milligrams per kilogram IV-IO. Protocol 16 is the post-resuscitative care pediatric protocol. Now, this protocol is based on blood pressure, blood glucose, and heart rate. No real change from your current protocols except for the post-intubation sedation if needed. And once again, if our patient has a return of spontaneous circulation, our I&P level providers will look at their blood pressure. And remember, hypotension is age-based. So normal saline boluses at 10 milliliters per kilogram if the lungs are clear, IV-IO, and dopamine 5 to 10 mics per kg per minute, IV-IO. And again, to review, the ketamine dose for post-intubation sedation is 0.1 to 1.5 milligrams per kilogram IV-IO. Just a note on ventilating your pediatric patients, hyperventilation is a significant cause of hypotension. Recurrence of cardiac arrest in post-resuscitation phase must be avoided. So we can do this by maintaining that appropriate end tidal of 35 to 45.